Welcome to our podcast, PA Mindset Matters. I'm Mercedes Dodge, and we're excited to introduce you to our mini mindset editions. With Jessica Spissinger and I, we've created these short episodes for PAs, PA students, and all healthcare providers who want a moment to pause, reset, and reconnect with purpose. In each episode, we will explore reflections, practical insights, and a mindset shift you can apply right away in your training and in practice and in life. Because how we think shapes how we show up for our patients, our colleagues, and ourselves. So let's get started. Well, we're going to do a deep dive today. I'm really excited about this topic. I think, you and I have talked about the mental health information we have for women in menopause. So we're going to talk about menopause and mental health. So many women and patients come in saying, I just don't feel like myself. Something's off, right? So the real question here is does it look like depression, anxiety, or is there actually like menopause related, hormone related changes that are occurring? I mean, I'm curious with you, Jessica. Have you run into that with patients coming in and you're like, where are you in your hormonal life?
Yeah, I feel like it was always in the back of my mind, but I would say that probably in about the past 6 to 8 years, there's been a rise in cultural awareness of menopause. And with that and perimenopause, with that, I have more and more patients who are coming to see me and they're like, I think it might be related to this. Whereas that was never really as much of the conversation previously.
I agree. I think that is just more of awareness and advocacy for your own health. And I'm glad to see that, changing. So here's where the cost of missing that menopause link. So it's really real. So in a midlife patient may be labeled standard major depression or anxiety, but there's actual drivers underneath. And we need to think about that endocrine instability that might be occurring. And we might catch it if we're capturing like sleep disruption, those hot flashes, those vasomotor symptoms. And maybe, you did start an SSRI or someone starts an SSRI and it's just partial response. You're not seeing something improving where you would think it was. And you're like, oh, is this treatment resistance? But I think what's helpful is you always have to have that lens. Who is the patient in front of you and what's going on in their life? And I'm not sure if I have a slide, but like perimenopause is a huge time period. And you can have symptoms of perimenopause anytime from like 30 to 60. And so that means clinicians need to have a large lens, right? And not just think this is just depression, because it really is important to validate and acknowledge what us women are going through midlife.
Yeah, absolutely. And, sometimes I think of it too as almost like what I say, like death by a thousand cuts, because it might just not be one thing. It might be a culmination of factors. Sometimes the perimenopause element is taking center stage. Sometimes it's more background noise, right? So between, situational stressors like physiological, psychological depression states, social stressors, and then we've got the whole hormone component. Sometimes it's a little bit muddy to clarify what's what.
Yeah, it's so muddy. Isn't that interesting? We have to be better in catching and being curious, right? And just not accepting things in plain sight. So a lot of women, so I like this slide. And you can use the iceberg analogy in so many things, not just menopause. And so I think that's why I like the iceberg analogy. So a lot of women will come in and maybe they have been having these symptoms for a long time and they attribute to it's just stress, right? We have this social stigma is like it's just us dealing with empty nesting, right? Or, I'm going through my period. So, but the physiology tells a different story. There's a lot going on during perimenopause that can look like irritability, tearfulness, and that brain fog. How many times have you come up with a patient that's like, I just can't think right? I mean, I guess I'm thinking about my own self, but that does happen during this stage. Do you not agree?
Completely agree. I feel like, so many women describe, and it kind of fits how I felt as well. Like you're kind of cruising along and you're learn so much about yourself in your 20s. And then in your 30s, you kind of hit your stride and you kind of know your body, you know yourself. And then you're rising into the peak of your career. And suddenly it's life takes this giant hairpin turn. And suddenly everything you've learned doesn't work. Everything that you like had relied on as like a system kind of starts to like dissipate and like trickle. And it really does start to feel, I hear this, from a lot of women. I experience it myself. Like you're suddenly on kind of shifting sands.
Yeah, and it kind of feels, do I should I believe what's going on? Is this really, really happening? And so there's like I think a denial component, to be honest, too, is
And
like,
there's no clear biological testing we can do.
No. Yeah. And I think that's what is a struggle when we're managing mental health in general, too, right? There's not something where
Exactly.
I'm going to take this specific blood test or your saliva and we got it all. And so putting all of the drivers in play and understanding the story, I think is really helpful. So just to kind of review a little bit of what's happening. So during perimenopause, a lot of things with the estrogen is fluctuating, as you all know. FSH is rising, and that impacts our circadian rhythm. We talk about sleep a lot, and we're going to do some more talks, I think, about sleep. But that combination feels awful. And I'm probably talking from personal experience, but also it's biologically real. And so to be able to validate and listen to our patients and realize, you know what, I need to take this in consideration and how do I help this driver when I'm doing treatment plans? So this is part where the brain's really kind of enters the story about what's changing. We talked a little bit about estrogen, but there's estrogen and progesterone not only affecting reproduction, so there's changes in our period and our ability to reproduce or get pregnant, but there's all other hormones involved, such as serotonin, dopamine, and GABA, which means there's going to be a lot of mood fluctuations. So we call this the window of vulnerability. And it can feel less stable during this transition. And there's evidence showing the changes in the brain, showing with heightened cortisol and emotional reactivity. So it's real biological changes happening in the brain that causes the body to feel more anxious or reactive, more overwhelmed. So that's why it's important to not just chalk it up as, oh, you're on your period or you're in menopause. There is physiological neurobiology in the background happening.
I feel like to some degree, it's like it's always been recognized. Like we have like a DSM diagnosis of like PMDD. We have a postpartum onset, and both states really
Hmm.
recognize the mood fluctuation in response to estrogen declining, kind of more rapid states of estrogen, but predictable rapid states of estrogen declining. And then in perimenopause, it's like it's completely ignored, but that is exactly what's happening. And it's not predictable
Hmm.
and it's erratic, but it really just has not been like fully acknowledged at all.
Yeah. And so we're going to break that. We're going to talk about it. So the data helps us like kind of move forward. I like this. The SWAN study. If you haven't heard about the SWAN study, look it up, look at it. There's a lot of good research on it. So basically what the SWAN study showed is there's a substantial proportion of women experiencing high depressive symptoms during perimenopause. And that risk of depression rises during this transition, even if women who have had no prior depressive disorder history. So what we want to know is that it's not just this happens because you've had a recurrent history of depression. It's really a vulnerable state situation, a subgroup. It can happen as your first onset of illness. So when midlife women start struggling, what we should think about is there a transition happening, not just a diagnosis? There's a lot of statistics here. I think ultimately what I want to know is how do you explain this to patients yourself, Jessica, with this transition?
A lot of patient education around the hormone fluctuations, but it's also kind of a lot of recognition that there's not really a lot of clear answers, and oftentimes try to see if we can like work collaborative with gynae providers as well. Really, it just depends on the specific patient.
Yeah. Yeah. And I think that you mentioned about that collaborative approach. And I think that that is also a missing piece in our medical service, or the thoughts is like we treat patients in silos, and we should really start collaborating or finding pathways to connect with OBGYN and women's health.
Yeah, I've had a couple of patients who, in conjunction with their gynae, they started hormone replacement therapy, and they were like, "I don't think I need my psychotropics anymore." And we took them off of it, and they really continue to do well. And it's like we are missing a very important gap here, very important
Mhm.
piece.
Yeah, yeah, and I really am glad that there's a lot more education about hormone replacement therapy and people getting more or clinicians getting more comfortable in prescribing it, not only primary care setting, but OBGYN, as well as asking if this is something that I could be part of my treatment. So the risk I was going to say is not distributed evenly, even though it can be the first presentation of depression or illness during the perimenopause vulnerable state. It is important to get good history. So reproductive psychiatric history is incredibly important. Getting a collection of, has there been postpartum depression? Has there been a history of severe PMS or PMDD? And if you're really going down that hole, is like, okay, when did your mother hit menopause, right? Getting those informations is really helpful. Getting a good sleep history is helpful. Trauma is also very important to ask as well. It could raise the odds that the transition in this phase hits harder, actually. So in
Mhm.
practice, make sure you take a good history. It's multifactorial. It's important that you don't just blame one or the other, is making that you're considering all pieces involved in this type of care.
100%.
So night sweats. So night sweats, hot flashes are not just like comfort problems. They can absolutely erode like the resilience and ability to function the next day. So sleep fragmentation is one of those things that we see during this vulnerable phase, but also can contribute to more dysregulation in mood. So the patient is no longer just tired. They're not able to regulate their mood or tolerate stress. We call it the frustration tolerance. And they can't think clearly because if you're not getting enough adequate sleep and hours, you're not giving the brain the resources to think sharply. So I often think of it as a triad. So trio, feedback loop. So estrogen fluctuations happening on the top here, and it leads to vasomotor symptoms like night sweats. Those vasomotor symptoms lead to sleep disruption, and the disrupted sleep leads to worsening mood. So we got to think, if a patient or a female patient is coming in with sleep issues and sleep disruption, take a lens back and think about, is there any possibility of vasomotor symptoms contributing to the mood?
Yeah, and sometimes it's not just to say it's not always just the vasomotor symptoms that happen too. Sometimes there'll be like those new onset spikes of anxiety that are resulting in people suddenly not sleeping where that was never an issue before. So it seems like there's multiple reasons why sleep can start to get more disrupted in the perimenopause and menopausal space.
Yeah, that's true. So brain fog, it can be one of those most frightening things, or at least it was very frightening for me and still is, because when we can't think clearly, it feels like something is awfully wrong. And am I having another condition? Dementia. Obviously it definitely is scary. 2/3 of women report memory issues during this transition. And so if you look back on the SWAN study, like I mentioned, read up on it if you haven't heard about it, it proves that this is temporary lack of the learning effects. So it's not a permanent cognitive decline. I'm not going to be like this forever. There is things that you have to adapt and optimize. And I think that's one of the learning pieces, is like, okay, well, what do I have control over? So yes, patients can request hormone replacement therapy, but also, is there anything that I can reduce stress? Is there anything that I need to do, like exercise? That helps a lot. So there's just so much things that we want to consider as helping the cognitive fogging or the brain fog. Often when you have brain fog, I think a lot of people go directly to ADHD. So it's important to recognize that the brain fog is driven by the drop of estrogen and the fragmented parts of sleep. Do you want to add anything to that?
Just to say, however, that this is a little bit of like a cultural phenomenon right now where it's a little bit of a perfect storm because the women who are now hitting like the perimenopause space were often, children in like the 80s and the 90s. And that's not really a
Mm.
time when ADHD was as recognized as it is now. And especially it was not recognized among women. So there's really been generations of women perhaps had ADHD, but it really wasn't caught at the time they got their way through. And then in the menopausal space, that vulnerability kind of gets rid of all of the compensation methods that had been working for them in their 20s and 30s. And so I'm starting to see this a lot. And when you look back, for those patients, I'm always trying to get data about childhood, right? So it's not just that this is happening now, but like, tell me more about what was going on for you, like as a kid. And they were like, oh, I was always just told I was lazy. I was always kind of daydreaming and I had dreams, but I wasn't able to realize them, even though everyone said I was smart. Like there's a lot of things you'll start to like tease out.
Yeah.
So just to say it is interesting and that, we just have to take the whole history into account.
Completely. And so I think it goes back to what I was saying, that we can't just tunnel vision to one thing or one condition or one symptom. Is important to have that lens and be able to take a step back and be like, okay, is there something else that we're missing? So taking into context, you're right. These females that are coming and presenting and looking for care for their perimenopause transition also might have been underdiagnosed, undiagnosed, never diagnosed with ADHD. So it's an opportunity to kind of do a further evaluation. So this is where good diagnosis really matters. And so perimenopausal mood symptoms can resemble depression or anxiety. Asking questions, getting a good history, like Jessica says, you want to know about the hot flashes, the night sweats, the sleep issues, the menstrual cycle changes. These clues really help separate if menopause is a component to the big picture.
Yeah. And there's like, I forget what it is, but there's something like maybe 40 plus different symptoms of perimenopause.
Yes.
So, we often think of like the hot sweats, but like joint pain can be one, like, of course, like the sleep, the mood, but there's like a whole host of other ones. Like it's just too many to even list.
Well, there is so many, right? So obviously educate yourself, especially if you're not a
Vaginal
female.
dryness.
You're like, maybe you can't, completely understand, but knowing that there is a variety of types of symptoms that can present. So treatment should match the clinical pattern. So not just the label, right? So if the mood symptoms come with vasomotor, think about SNRIs. SNRIs target both mood and some vasomotor symptoms, actually better than SSRIs. So that's one of my big clinical pearls. If there's sleep disruption, is the bigger issue, right? Like which one's the most impact functionality issue, then you might want to do the hormone replacement therapy or think about gabapentin, has some research behind that. If there is that more of that cognitive symptoms, of course, rule out other things like ADHD that's never been diagnosed, but the cognitive symptoms do help with sleep hygiene, CBT, that yoga and mindfulness practices. I think one of the big warnings that I put on the bottom is avoid paroxetine, known as Paxil, for many reasons, but it definitely has drug-drug interactions with other medications. So I just wanted to go over like a case. So you have a patient, Maria, she's 49. She's tried SSRIs, and it helps with her anxiety, but she's still exhausted. You catch that there's still some tearfulness and maybe you're thinking, oh my gosh, she's treatment resistant. I thought I'd maximize or optimize her SSRI, but you take a step back, you notice that she has night sweats or maybe just periods of vasomotor symptoms or vaginal dryness, like you said, and that's been causing a lot of problems and leading to the mood symptoms. And so in this case, you switch your lens and say, okay, well, maybe we should try an SNRI. So that was basic. Don't think it's just treatment resistant. Think about the whole picture of what Maria is going through. So practical point here is treatment is going to really help match the symptom pattern that Maria might have. And so just 5 clinical pearls that really stick. Screen for vasomotor symptoms. So we all know about hot flashes and night sweats, but there's more. Get a good menstrual timeline. Treat
Mhm.
sleep. Consider SNRIs, especially when vasomotor symptoms are present. And reassure the patient that the brain fog usually is temporary. That probably could be your key, is that, wow, this brain fog is not improving. Well, then reassess and see if something else going on. But it's not dementia, I found out. So that's basically my 5 pearls. And then this slide is just really looking that it's not an isolated event. We just talked about perimenopause and menopause today, but there's a lot of other mental health conditions that we're more aware of. So postpartum and postpartum depression, also anxiety during this phase of pregnancy. And then there's the PMS and PMDD during the initiation of period and throughout time. So just having a perspective of women's mental health is really about a reproductive timeline, and they're all interconnected with windows of vulnerability, but shifting of mood. So we want to be proactive, right? And we want to think about the pattern and be
Yeah.
compassionate to our women.
Yeah.
And then,
I just wanna say,
yeah,
like, I have a lot of hope that we've really started this whole, like, cultural phenomenon. Like, I feel like my generation and, us Gen Xers have really, like, kinda pushed this into greater cultural awareness because it used to be something that really, like, women didn't like to talk about.
yeah, no, we're making it topic that's more normalized. And I think that's really important. So these are the key references that we kind of mentioned through the episode. We talked about the SWAN study. I took some of the information for the slides from a Harvard study of mood and cycling. There is some best practices in women's mental health. AAPA, our organization, is having a lot of good CME and guidelines being posted online. There's also the JAMA Psychiatry. So there's a lot of information out there if you're looking for how do I dive into the evidence and research. But that is a wrap. I had cases, but we're not going to do cases. But thank you guys so much for joining. I hope that was a deep dive of some of the information and the hope, like Jessica says, on mental health for women. Join us next
See
time.
you later.
Thanks for being here with us at Mini Mindset Series. Our hope with this is simple, that one small insight today sparks a different question, a different conversation, maybe even a different outcome for one patient. Because small mindset shifts ripple into clinic, into leadership, into life. Until next time, take care of your patients and take care of the clinician inside of you too.